Hi, my name is Morgan Cervera, and I'm a second-year graduate student in the athletic training program at McKendree. Throughout the past 8 months, I have been conducting research on the effectiveness of therapeutic interventions and management of symptoms of autoimmune diseases, specifically systemic lupus erythematosus and rheumatoid arthritis. This area of study is important to the athletic training profession because of the lack of knowledge most clinicians have of autoimmune diseases. Generally, there is no cure for autoimmune diseases, although symptoms can be managed throughout various treatment options. When presented with an athlete that has an autoimmune disease, finding a way to help them manage their symptoms so they can live the most normal life they can is the main purpose of this research. The research question for the study is, what is the effectiveness of therapeutic interventions on management of symptoms of SLE and RA? The hypothesis is directional toward the use of therapeutic interventions in helping the management of symptoms of autoimmune diseases. In the clinic setting, not many clinicians are educated on autoimmune diseases and how these diseases affect the body and make the patient feel. Educating clinicians would help in the treatment and management of patients with these diseases. By using therapeutic modalities, therapeutic exercise, and counseling patients to stay optimistic and adhere to the treatment plan are all aspects that will help improve the quality of life of patients with autoimmune diseases. Adherence and patient compliance are important aspects of the success of interventions, along with patient education. Before continuing on with the presentation, here are a glossary of terms to help better understand the rest of the presentation. Renal, relating to the kidneys. Hematological abnormalities, involve the blood and include problems with red blood cells, white blood cells, platelets, bone marrow, lymph nodes, and the spleen. Serositis, inflammation of the serous membrane. Radiocarpal, where the radius bone of the forearm meets the first row of carpal bones in the lower hand. Intercarpal, situated between, occurring between, or connecting the carpal bones. Proximal interphalangeal, the middle knuckles of the finger. Metacarpal phalangeal, located where the hands, fingers, and thumb meet the palm. Overlap between two or more autoimmune diseases is common. Lupus is a term given to patients with overlapping features of RA and SLE. Comparing non-lupus SLE patients with lupus patients are shown to have a higher cumulative erosive burden on MRI and CT scans, while there is no statistical difference between lupus patients and RA patients. The most frequently reported SLE features in lupus patients are skin and mucosal involvement, renal involvement, hematological abnormalities, fever, and serositis. Lupus patients demonstrated less frequent neurological involvement when compared to SLE patients. The most affected joints in lupus individuals are the radiocarpal, intercarpal, proximal interphalangeal, and metacarpal phalangeal joints. Hand arthritis, polyarthritis, symmetrical arthritis, joint swelling, morning stiffness, and joint deformities are significantly more common in lupus patients than in SLE patients, while there is no significant difference when compared to RA patients. It is thought that genetic factors interact with the environmental exposures throughout the lifespan to influence susceptibility to development of SLE. Having a family history of SLE or related autoimmune diseases dramatically increases the risk of SLE, but patients that have low genetic risk factors and do not have a family history highlights the importance of environmental factors on the development of SLE. Some of these environmental factors include crystalline silica exposure, current cigarette smoking, alcohol consumption, and exogenous estrogens like oral contraceptives and postmenopausal hormones. UV radiation, solvents, and pesticides have also been linked to SLE development. Different types of dust, which likely include silica, silicates, and carbon nanotubes, have been associated with markers of increased systemic inflammation years after exposure. Cigarette smoking stimulates certain expression on T and B cell surfaces, which has been linked to potentially inducing autoimmunity. It also increases the production of pro-inflammatory cytokines. Ultraviolet light exposure has been known to exacerbate pre-existing lupus, but it is unknown whether UV exposure is involved in SLE pathogenesis. Alcohol contains compounds such as ethanol and antioxidants that can potentially counteract the systemic inflammation. Long-term moderate alcohol consumption was associated with lower risk of SLE incidence. Many genetic and environmental factors have been associated with an increased risk in developing RA. The strongest associations have been seen with family history, female sex, the genetic factor, the shared epitope, and exposure to tobacco smoke. Several of these associations have only been seen in single studies, but the one environmental factor that remains consistent between studies is exposure to tobacco smoke. It has also been considered that smoking increases the risk of periodontal and lung disease that may act as a factor that increases inflammation and autoimmunity. Some other environmental factors associated with increased RA risk include female sex, occupational dust or silica, air pollution, high sodium, red meat, iron consumption, obesity, and low vitamin D intake levels. Healthy lifestyles, including lower body mass index and healthier diets that include low in sugar and animal fats and higher in fruits, whole grains, and vegetables, have all been associated with a decreased risk of RA. The main goal of therapies for treatment of RA and SLE are aimed at suppressing the signs, symptoms, and progression of the disease. Pharmacological treatments are typically used in any patient that has established RA or SLE. The main approaches include non-steroidal anti-inflammatory drugs, or NSAIDs, glucocorticoids, disease-modifying anti-rheumatic drugs, or DMARDs, and some biological agents. Non-steroidal anti-inflammatory drugs are commonly used for treatment of RA due to their quick onset of analgesic effects and minor anti-inflammatory properties. NSAIDs are used as more of an adjunct rather than the only treatment method. Glucocorticoids have been used in the treatment of inflammatory arthritis. This treatment option is used as a therapeutic adjunct in low doses or as a bridge therapy used when disease activity is high. Disease-modifying anti-rheumatic drugs have a slow onset of action compared with NSAIDs and glucocorticoids. The suppression of the signs and symptoms of inflammation may not be noticeable until months after the initial start of therapy. Many patients stop therapy with DMARDs after a few years due to the lack of efficacy or development of side effects. Immunosuppressive medications help suppress the immune system. These drugs have been used in the treatment of certain autoimmune diseases such as SLE and RA. With lupus, the body mistakenly attacks their own body tissues. These medications work to suppress this attack by preventing the immune system cells from dividing. Since immunosuppressive drugs decrease the immune system's activity, people taking them are at a higher risk for infection. It has been hypothesized that exercise training, if able to alleviate the inflammatory process, could also be helpful in treating the symptoms as well as modifying the disease's natural course of activity. Current literature supports that exercise training is a safe and effective way to improve several clinical outcomes in SLE patients, such as depression, fatigue, autonomic control, aerobic capacity, and health-related quality of life. When compared to healthy subjects, exercise virtually reversed autonomic dysfunction in SLE patients, with autonomic control parameters being comparable between patients and controls. Exercise training has been thought to have a synergistic beneficial effect in the management of SLE, but more controlled clinical trials are necessary to confirm and support this statement. RA is the most studied autoimmune rheumatic disease in the context of exercise training. There is strong evidence that shows the benefits of moderate and high intensity exercise training on aerobic capacity, fatigue, muscle strength, pain, and disabilities in patients with RA. This research design is a systematic review of the effects of therapeutic intervention on managing the symptoms of RA and SLE. The research approach for this study is a meta-analysis, which refers to the statistical analysis of the data from independent primary studies focused on the same question. The population used in this study were those diagnosed with SLE and/or RA or vice versa. There were no restrictions placed on age, sex, gender, or race. There were also no restrictions placed on the level of severity of disease development. The success rate of interventions will take the severity of disease into consideration when analyzing results. The databases used to obtain peer-reviewed articles included PubMed, Google Scholar, and Abisco. Materials used in this research were previously conducted case studies, controlled clinical trials, systematic reviews, and meta-analysis peer-reviewed articles regarding therapeutic intervention in management of symptoms in SLE and RA. The possible variables in this study include the severity of the disease, the age of the patient, how long the disease has been present, gender, the use of pharmacological agents in conjunction with therapeutic intervention, race, and patient compliance to therapeutic intervention. A limitation of this study is the available research that looks at patients with RA and SLE that are still physically active. Another limitation of the study is that each patient in each study physiologically responds differently. Lastly, another limitation of this study includes any other underlying medical health conditions that patients may have that could affect their response to treatment. A delimitation of this study is the population chosen to target. This research is targeting autoimmune diseases, specifically analyzing RA and SLE. The main therapeutic interventions that were analyzed were therapeutic exercise and therapeutic modalities. Analyzing SLE patients that remained active or participated in exercise interventions showed to be safe and adverse effects were rare. A common trend among various studies showed that exercise did not adversely affect overall disease activity, but it did have positive effects on cardiorespiratory capacity, positively influenced depression, and reduced fatigue when compared to control groups. When evaluating the effectiveness of exercise on RA patients, most studies reported no influence on disease activity, although a decrease was reported in 3 studies. There are many therapeutic modalities that are available in the athletic training room to aid in the management of RA and SLE symptoms. For purpose of this research, thermotherapy, electrotherapy, laser therapy, spa therapy, and manual therapy were the modalities of focus. Thermotherapy includes local cold, ice packs, ice massage, cryo wraps, cold air, and vapocoolant sprays, and heat, superficial heat including hot packs, paraffin, thermal baths, and infrared, deep heat including electromagnetic waveforms and ultrasound. For both RA and SLE, a variety of different thermotherapy applications were used, and no significant effect of hot or cold applications on measures of disease activity, including joint swelling, range of motion, pain, grip strength, or hand function were noted when compared to a control group. Regarding objective measures, paraffin did show positive results for RA hands with range of motion, grip strength, pinch junction, stiffness, and pain after 4 consecutive weeks of treatment. Cold application showed temporary relief of pain, but no effectiveness regarding disease activity. Evaluating the effectiveness of electrotherapy on pain control, results are conflicting. No statistically significant difference was noted in management of pain. The use of electrotherapy for muscle stimulation was shown to be effective in increasing muscle strength and endurance. According to trials done evaluating laser therapy and treatment of autoimmune diseases like RA and SLE, results suggested that low-level laser therapy was effective in reducing morning stiffness and pain. Spa therapy included mineral baths plus mud packs, radon carbon dioxide baths, and sulfur baths. Most of these trials demonstrated positive results regarding morning stiffness, pain, and functional ability. The purpose of this research was to analyze the effectiveness of therapeutic interventions, including therapeutic exercise and therapeutic modalities, on managing symptoms of autoimmune diseases, specifically rheumatoid arthritis, RA, and systemic lupus erythematosus, or SLE. Based on the results found regarding therapeutic exercise programs are considered safe and do not adversely affect disease activity of SLE. A multimodal approach is suggested when treating a patient with SLE for best patient care. Therapeutic exercise and management of RA patients showed improvements in muscle function, aerobic capacity, and physical performance with functional tasks in short-term evaluation. Long-term exercise results have yet to show significant improvements. Use of therapeutic exercise for RA patients are considered safe and is recommended in a multimodal approach as well for best patient care. None of the therapeutic modalities that were evaluated caused any adverse effects or increase in disease activity, so use of therapeutic modalities is considered safe and is recommended in conjunction with therapeutic exercise. These findings will help the profession of athletic training by giving a better understanding of what interventions have shown to decrease symptoms and help athletic trainers' ability to create a treatment plan for an athlete with an autoimmune disease. More studies in patients with RA and SLE need to be conducted to support the effectiveness of non-pharmacological treatment strategies. Future research could include less multimodal approaches to try to narrow the point of research and see what intervention is improving symptoms. Future studies could compare the effectiveness of multimodal approaches of intervention versus unimodal approaches of intervention. Examples of potential future research questions are shown.